Good evening once again to everybody. Thank you for joining us on this March meeting of the Nigerian Society for Colorectal Disorders. In the house, we have one of our very erudite members, Dr. Kunle Oke, who is a consultant gastroenterological surgeon and the consultant and colorectal surgeon with Sapphire Surgical Center in Lagos. So he's here to talk about an interesting topic called the Crimson Gut, managing life-threatening gastrointestinal bleeding. So I'm sure that we'll have a nice time during the presentation. And as usual, the floor will be open for questions and answers at the end, which will be moderated by Mr. Emmanuel Ogori. So I'd like to hand over the platform to Dr. Oke. Over to you, sir.
Thank you, Mr. President. Good evening, everyone, and thank you for the opportunity given to me to practice my speaking skills again. It's always a terrifying thing for me to speak in front of a large audience, but thank you for your support. So the topic today is the Crimson Gut. It's essentially a gut filled with blood. And how did we come up with this topic? A few weeks ago, I was asked to see a 68-year-old man who had presented to a hospital in Victoria Island with hematochezia and syncope. He had been bleeding for 4 days and he had been on admission at this hospital. There was no endoscopist to perform a colonoscopy. He was placed in the ICU and was being resuscitated. Comorbidity, he's hypertensive on amlodipine, which he takes regularly. He's not on antiplatelets or anticoagulants. Prior to seeing him, he had been sent to another hospital for mesenteric angiography because they could not get an endoscopy on a weekend in Victoria Island. The interventional radiologist performed a mesenteric angiography and did not see anything. And so he asked me to perform a colonoscopy. When I saw him, his blood pressure was 80/50 millimeters of mercury. Remember, this is the 4th day of his symptoms. He was otherwise well before this presentation. Heart rate was 125 beats per minute. And the most recent hemoglobin that morning was 4.5 grams. So it was very low from someone with a steady state hemoglobin of 14 grams. I would like to ask the House, I do not have a voting system here, but just ask and you answer to yourself, what should be our first priority here? Okay, with that question hanging in the air, I will move on to define massive gastrointestinal bleeding or hemorrhage. It's bleeding from any part of the gastrointestinal tract, which is severe enough to cause hemodynamic instability, requires more than 4 to 6 units of red blood cell transfusion in 24 hours and is associated with rapid ongoing blood loss. The NHS transfusion service defines this as the loss of 1 blood volume in 24 hours. That's about 70 mils per kilogram body weight, or the loss of 50% of the total blood volume within 3 hours of onset, or blood loss of more than 150 mil per minute. And the clinical indicators are hypertension, systolic blood pressure less than 90 millimeters of mercury, and a heart rate more than 110 beats per minute. Gastrointestinal bleeding is it's common and its incidence increases with age, with advancements in years across the world. A lot of the good data, unfortunately, comes from the Western world, and I've chosen to use data from the US and the United Kingdom. In the United States, there are 400,000 hospitalizations per year. Upper GI bleeding, which is bleeding proximal to the ligament of Treitz, is said to have an incidence of 15 to 172 per 100,000 person years. Lower gastrointestinal bleeding is much less, about a third of that, at 20.5 to 87 per 100,000 person years. 15% of cases of GI bleeding are massive. Mortality in the Western world is quoted usually between 10 and 24%. Factors associated with increased mortality, again, mirror massive gastrointestinal bleeding as I had defined, which is the requirement for at least 4 units of blood, higher degrees of shock. Patients who developed gastrointestinal bleeding in the hospital because their physiological makeup is already under stress from whatever illness brought them to admission in the first instance. The presence, number, and severity of comorbidities also speak to physiological stresses and loss of physiological reserve, which is now compounded by massive gastrointestinal bleeding. The common causes are variceal or non-variceal. Esophageal varices are the consequence of chronic liver disease, usually. But non-variceal causes in the upper gastrointestinal tract are even more common. Peptic ulcer disease is the most common cause of massive gastrointestinal bleeding virtually anywhere in the world. Other causes are up there in the slide. For lower gastrointestinal bleeding, the commonest cause is diverticular bleeding. And in fact, some people would like to divide the lower gastrointestinal tract into the colon and, in quote, the middle lower gastrointestinal tract, which is the small bowel distal to the ligament of Treitz. Whatever the case may be, diverticular bleeding is still the most common cause in most parts of the world. But it's important to note that a patient presenting with hematochezia and hemodynamic instability may actually be bleeding briskly from an upper GI source. There is not a lot of high quality data from Nigeria, but I will still give kudos to those who have taken time out to gather data and share with us. And it's from their data, Oluyemi et al. In Lagos, that we know that the commonest causes of gastrointestinal bleeding, mind you, not massive, this is gastrointestinal bleeding in general, are hemorrhoids, diverticulosis, and tumors. With hemorrhoids being more common in younger people and tumors increasingly more common with advancing age. In the upper GI, Ademola from Maiduguri, from Makurdi, identified peptic ulcer disease and esophageal varices as the commonest causes of massive gastrointestinal bleeding. Now, massive gastrointestinal bleeding is a life-threatening condition, and dealing with it requires a lot of speed and intentional interventions that are well practiced by a team if we're going to save the patient. Treatment starts with a rapid initial assessment, focus history, physical examination, hemogram, which includes a full blood count and a few other laboratory parameters. We use the tried and tested ABCD approach to resuscitation with focus on the airway and hemodynamic status of the patient. I want to rule out an altered mentation or mental status of the patient. which suggests severe shock, which may be seen in massive gastrointestinal bleeding. It's also important to note that this initial assessment should go on pari passu with hemodynamic resuscitation. Where available, and it's increasingly more available in Nigeria now, CT angiogram, if the patient has been resuscitated and may be fit enough, to enter into a scanner, enables crude localization and gives one an idea, of the part of the bowel that this bleeding is coming from. We know that a nasogastric tube can be passed in brisk bleeding to rule out an upper GI source. Again, this is very crude and may not always be reliable, because you may not see anything in it, but the bleeding is actually from the upper gut, only just distal to a competent pylorus. It's important to quickly assess the risk to this patient of adverse events, and also to triage the patient. Triage is important so that we'll know the timing for endoscopy generally, and whether this patient who has come in shock will need us to activate the massive transfusion protocols. A tried and tested method, well, what we all use is vital signs, which we all know very well. And with our improving clinical judgment, the more experience you are as a doctor, you may actually be able to determine, the danger to the patient just from looking at the vital signs. But more objective scores include the shock index, which is really simple. It's heart rate over systolic blood pressure. If it's greater than 1, it suggests that there is active bleeding. If it's less than 1, the patient is probably not bleeding at the moment, and gives you time to explore more options. But the most prestigious guidelines in the world use the Glasgow Blatchford score, which is a composite of blood urea, nitrogen, hemoglobin, systolic blood pressure again, pulse rate, melena, syncope, and comorbidities such as hepatic disease and cardiac failure. This is scored, and a score of 0 to 1 more or less rules out massive gastrointestinal bleeding. But this is a useful score while you are resuscitating or after resuscitation. There are newer experimental methods of risk assessment, such as the use of AI telemetry capsules. Telemetry capsules use spectrometry to detect blood in the gut. The problem with them, though, is that if the source of bleeding is an obstructive source, then they get caught up within the gut, and that adds to the problem that we're trying to solve. Resuscitation is the central theme of management of massive gastrointestinal bleeding. It is the main cause of mortality. It is one of the main causes of mortality. The main cause of mortality in this patient is really the number of comorbidities they have. And really, the younger the patient is, the more likely it is that with adequate intervention, the patient will survive. But if hemodynamic resuscitation is not done properly, nobody will survive, no matter the number of comorbidities they have or do not have. Hemodynamic instability, the goal really is normalization of blood pressure and heart rate prior to further evaluation and intervention. We're advised to pass through 18G peripheral catheters and infuse crystalloids. It's also important, once you assess the patient as having massive gastrointestinal bleeding to involve critical care. A restrictive transfusion strategy is also very useful here. There is no point in overloading the patient with blood. And as such, a hemoglobin of 7 grams per deciliter is a sort of cutoff line for most otherwise healthy people. This tends to usually be the younger people. For older people with significant comorbidities, cardiovascular ischemia, and so on, the transfusion, I would not want to use the word trigger, but then maybe that's the right word here. Trigger should be about 9 grams per deciliter. For those who are going to have a possible delay in receiving therapeutic intervention, we should also be more liberal with transfusion because you don't know when they will get there and they could bleed to death before they can get intervention. And in our environment, this may be more common than in the Western world due to the difficulties with getting therapeutic interventions. I brought up damage control resuscitation here, and I know that a lot of people on this platform know this as associated with trauma. And in the management of massive gastrointestinal bleeding, the idea is very similar. The aim is to protect the patient from, falling prey to the lethal triad of coagulopathy, acidosis, and hypothermia through early balanced blood product transfusions. The aim is to achieve a high plasma to platelet ratio. This prevents dilution coagulopathy and makes sure that platelets are always available in order to form a stable clot and hopefully stop the bleeding. In damage control resuscitation, we limit crystalloid use. And these are patients that may be exsanguinating from their bleeding source. And we also make use of permissive hypotension. And as such, the systolic blood pressure, unlike what I said before, may be considered adequate at between 80 and 90 millimeters of mercury before moving on to the next stage of management of this patient. This requires the facility to have a massive transfusion protocol and acute GI bleed protocol because the management of these cases requires speed, and that is the only way they can survive. A lot of these patients are older, they have comorbidities, and they tend to be on anticoagulants in any part of the world, really. A lot of these anticoagulants are not really within the competencies of a colorectal surgeon or a gastrointestinal surgeon for that matter, and it behoves us to activate a multidisciplinary team, including hematologists. I did mention critical care earlier on, cardiologists who would assist, in making these decisions to balance the risk, of ongoing bleeding with the risk of thromboembolic events. For antiplatelets, we are advised to continue aspirin if it's for secondary prophylaxis, but if it's for primary prophylaxis, then we are advised to stop it once and for all. Some of these patients will be on warfarin. We can reverse this with low-dose vitamin K combined with prothrombin complex concentrates, which unfortunately is not available for use, in Lagos, not readily available for use in Lagos, or fresh frozen plasma, which most of us will be familiar with. A lot of us use tranexamic acid in trauma and virtually any situation in which a patient bleeds. But the ALTI trial has suggested that tranexamic acid in massive gastrointestinal bleeding does not improve survival, and it actually does increase the risk of thrombotic events, of thromboembolic events. And so tranexamic acid is increasingly being discouraged in most of the top guidelines that speak to massive gastrointestinal bleeding. Direct oral anticoagulants may require specific reversal agents. Before this discussion, I spoke to my pharmacist, and it's interesting that some of them are available in Lagos. It's going to get me the prices. Because we're dealing with massive gastrointestinal bleeding, in addition to aggressive resuscitation, there is a need for urgent endoscopy. And the question is, at what point do you take the patient, do you perform endoscopy on the patient, especially in patients with anticoagulant medications? If the INR is high, what do you do? We're advised to go ahead if the patient is really dire with an INR of 1.5 to 2.5. If the patient has an INR greater than 2.5, it may be safer to continue resuscitation while we try to reverse the INR, as previously described. Platelet transfusions are also important to support any intervention that we want to perform in these patients, especially when the count has dropped below 50,000. I did mention a massive transfusion protocol earlier on. Massive transfusion protocol, a part of it involves monitoring the quality of the clot that is being formed with our interventions. Increasingly in Western hospitals, thromboelastography is being used, rotating thromboelastometry is being used. I've had some experience with TEG, but I haven't seen it in use in Nigeria. I will say that in this country, we will still continue with our PT, PTTK, PT, INR. It may take some time, but it is what we have. So once we have been able to stabilize the patient, the next thing is endoscopy. It is strongly recommended that endoscopy is performed within 12 to 24 hours of stabilization. Within 12 hours, if the patient has come with variceal bleeding, and not more than 24 hours in every other situation. Variceal bleeding can be significant, and sometimes we want to intubate these patients. This is why we do A, B, C, D, E approach. But evidence has suggested that we could withhold intubation, except in extreme circumstances. For gastroscopy, prokinetics have been shown to improve visualization. There is a role for gastric lavage, but in massive bleeding, it may not work. For lower gastrointestinal bleeding, a full mechanical bowel prep may not be possible because patient may not be able to tolerate it. In patients in whom we are able to catch up with the losses with resuscitation, it may be possible to pass an esophageal tube and infuse 4 to 6 liters of polyethylene glycol over 3 to 4 hours, and then take them for colonoscopy. Sometimes patients are bleeding so quickly that you could do this and the place is still not clean. One could combine that with phosphate enemas and water or saline irrigation during intubation with a foot pump if it's available. Now, what are the principles of endoscopy? It's to localize the bleeding source and achieve hemostasis. Patient is bleeding nonstop. I did mention the use of irrigation during intubation with a water pump, but on the newer machines such as Olympus Evis X1, I've seen this only once, and I've not seen it anywhere in Nigeria yet. But then I don't travel a lot. There are special light modes such as the Adeyeye mode, which can show you in a pool of blood where the fountain is exactly, and then you can go for that in the pool of blood. And then for patients with Forest 1A to 2A active bleeding, we are advised to perform endotherapy. The possible modes of endotherapy are in the diagram, to your right. It's important to note that upper GI sources of bleeding come from organs like the stomach, which are thick-walled compared with the colon, which is thin-walled. And so one should consider this when one selects what one has decided to use to achieve bleeding. In the stomach, it is possible to use big clips like the over-the-scope Ovesco clip that is in this picture. It's actually good for ulcers, for malarialized tears. Hemostatic clips are generally good for open wounds like small ulcers or post-cholecyst or post-polypectomy bleeds to close the wound and also secure hemostasis. Varicose band ligation is a tried and tested option for varices. Now, what of cases in which the bleeding is coming from telangiectasias, like radiation proctitis or radiation colitis or radiation gastritis? An option that I've not put here is argon plasma coagulation laser, which is very, very useful in this situation. For radiation proctitis, if you don't have argon plasma, the APC laser, it is also possible to use dilute formaldehyde to irrigate the bleeding mucosa for a minute or two and wash out as soon as possible. If it is left in contact for much longer than that, it could lead to necrosis, sepsis, and compound the situation. This is a picture of an over-the-scope clip. We usually call it the Ovesco clip. In these images, it's being used to stop bleeding from a malarialized tear. Interventional radiology is, in most guidelines, the next step. In my patient, it was considered the next step because colonoscopy was not available. In some guidelines, interventional radiology or endoscopy will be considered equal, and it may be possible to use any depending on what you have at the time. So it's a valid alternative as an initial option or the next step after a failed endoscopic intervention. And what is done essentially is to identify a contrast blush as is seen in these images, and then perform transarterial embolization using a variety of devices and agents. The biggest problem with embolization is obviously bowel ischemia, because if you block a major blood vessel, you are not only stopping bleeding, you're also preventing that bowel from getting the nutrition it needs to survive. This has not been really, well studied in the long term. We talk about bleeding risk in the short term of 10 to 50%, but it's an area that requires more research. Surgery is the last resort in most parts of the world, and I'm not saying most parts of the world, in the developed world in particular. And it is believed and advised in many guidelines that one should do everything to solve the problem before one gets to surgery. But a number of people may need to get to surgery. The reason why surgery is discouraged is that usually these patients are very, very sick. They have a lot of comorbidities. On a good day, they're not fit for a haircut, but now they're in front of you, and the only way to save them is that haircut. It's a situation that requires a high-risk consent, and the patient might still end up demising. What are the principles? Damage control, rapid stabilization, find the bleeding source and control it. This may require oversewing of duodenal ulcer, segmental bowel resection or subtotal colectomy, if one cannot make out the exact source of bleeding. Stage procedures may be necessary. As we all know, it's not always safe to anastomose bowel when the conditions are not right. In this patient, sometimes resuscitation may need to go, to be carried on pari passu with surgery and may actually continue beyond surgery and may not be the safest situation to anastomose, especially after bowel resection. And it's not failure to perform to give these patients a stoma and come back at a later date when they're much better to join them up. I've just spoken about examples of surgical intervention, but something that's not so uncommon in our environment actually is wedge resection of gastrointestinal stromal tumors, usually in the fundus or greater curvature of the stomach, in my experience. The not so common gastric cancer may be bleeding and may require emergency gastrectomy. So back to my clinical case. Patients, like I said, had been persistently hypotensive and had massive hematochezia for 4 days before I saw, and I determined at the time that resuscitation was inadequate. In fact, I decided to take over resuscitation in this patient, went away, came back after 4 hours, and my goals had not been met. So I discussed with and in addition, I was expected to perform this colonoscopy in an outpatient department that was remote from the main hospital facility. So I discussed with my partner and we decided to move the patient to our facility, which is primed for gastrointestinal interventions. And on arrival at our facility, we could now use our own protocol, which is aggressive resuscitation. He was admitted to the ICU. We activated the massive transfusion protocol, which sort of helped, but the bleeding was ongoing. So after a while, we decided to take the patient to theater. He was placed under anesthesia, and we performed gastroscopy and colonoscopy on table. This is gastroscopy. Sorry, this image is not great, but I can assure you, it was far better than this on that day with the Fujinon system. So his stomach was completely normal. That's the NG tube that I passed after discussions with Mr. Tunde Lalude, who's a more senior colorectal surgeon in Lagos. This is his colon. Had given him phosphate enemas and was irrigating as I intubated. I can assure you that colonoscopy is not the easiest thing you could do in a patient with ongoing colonic bleeding. This was very difficult, and I think it must have lasted up to 30 minutes for me to get to the cecum. Here, it's difficult to see because the intraluminal blood was sucking a lot of my light, even with all the ongoing irrigation I was doing. But I tried to highlight some of the diverticular that I saw in this patient. He actually had a lot of diverticular in the proximal colon, from the proximal transverse colon all the way into the cecum. And so we saw that and we asked ourselves, okay, so during this time, he was still being resuscitated on table, and we looked at the parameters and realized that he was beginning to come to. So we asked ourselves, what next? We decided to look at what was coming out of the ileocecal valve and realized that what was coming out of the ileocecal valve was clear, normal bile, and decided that this was a colonic bleeding source. We could not make out an exact source. So we decided to go ahead with subtotal colectomy, which he had. By the time we were done with the sleeve subtotal colectomy, he was hemodynamically stable. He had received 6 units of blood, and his blood pressure had come back to normal. So we had a quick conference on table. Do we anastomose or not? A lot of trepidation at the time, but with the data in front of us that this chap was hemodynamically stable, and we looked at our wound, there was no further bleeding. We decided to anastomose. In retrospect, that was a good decision because he did not leak. But at the same time, when we got to know him better, he may not have tolerated the stoma. So he was discharged from the ICU on postoperative day 4. What were the challenges? Blood products were scarce. It was O negative, and we sweated a lot to get blood products for him. But in the end, we were able to get 14 units of blood, which means that where there's a will, there's a way. He also had transfusion reactions. Again, fortunately, we had a professor of hematology in our team, so she was able to handle that. But something very interesting is that he came down with severe malaria, 3 or 4 pluses, and he was very, very symptomatic. I think this for me was, I told myself, dude, you are a rookie. How could you not consider that in Nigeria? Well, eventually he got treated for his malaria, and he's well and happy. So what are the tips for success? And I say this with my experience in Lagos. Massive gastrointestinal bleeding should be managed by a well-practiced multidisciplinary team of skilled specialists. Otherwise, there'll be a lot of mortality. We're in Nigeria, but even in Nigeria, we should have centers of excellence that we can refer our patients to. Centers of excellence must have skilled specialists who can perform endoscopy, interventional radiology, great surgeons, great intensivists, a fantastic blood bank. This is very important. But if that is not available, and even in Lagos, that is not always available, it is good to network with our colleagues and sit down, discuss these problems before they happen, and agree on what should be appropriate referral procedures and logistics for transferring these patients around so that they can get the treatment that they need promptly. Our limitations are obvious in our country. We are doing the best we can, but we still need a lot of training. Unfortunately, patients still pay out of pocket. An Ovesco clip, the last time I ordered for a patient, cost $1 million a clip. If I had to use 2 or 3 of those in a patient, he will be ruined by the end of my treatment. So this reduces our options in our environments, and eventually a lot of patients may still end up on the operating table. The key take-home message is resuscitation comes first, no doubt about that. It's good for us to, as colorectal surgeons and surgical gastroenterologists, to learn endoscopy because it saves lives. Interventional radiology and surgery are crucial when endoscopy fails, and team-based management improves outcomes. So in conclusion, in massive gastrointestinal hemorrhage, survival is really not determined by the severity of bleeding, but by the speed and the coordination of response. And with that, I've come to the end. These are my references, and thank you. I'm open for questions.
Thank you, Dr. Oke, for this very enlightening presentation. And we're very grateful that we had a very good outcome with the patient and that was managed. So I'd like to hand over the platform to Mr. Emmanuel Guaren, who's our international rapporteur, to coordinate the question and answer session. Thank you.
Great. Thank you so much, Dr. Oke, for that very challenging case you presented.
Thank you,
Well
sir.
done. And every time I just try and pinch myself to remind myself of the situation of the kind of restrictions and handicaps you are working with. You know, just in terms of the lessons for us to learn, please, I will welcome the questions. So if you can just write out your questions on the chat site, or if you want to say ask the question verbally, please just indicate by uh, the raised hand symbol, and then we can call on you. For us to be able to see that, please can we stop the presentation so that we can see everyone? Thank you. Yes, thank you so much. So the first question, or by way of lessons, is just the issue of the mesenteric angiography. To what goal was it? Was it for embolectomy, or embolization, or just to identify the source of the bleeding when this patient was sent for the angiography?
So at the time, the hospital, in fairness to them, was at a loss for what to do because they didn't have access to um, colonoscopy, well, to an endoscopist over the weekend. And they were looking for a way to stop the bleeding and decided to send the patient to the interventional radiologist in Victoria Island, Dr. Inolowo, to see if he could determine the source of bleeding with mesenteric angiography. He couldn't.
Yeah, it goes because one of the limitations again is for the bleeding could be intermittent, or for you to actually have a positive angiography, the patient must be constantly bleeding at least 0.5 mils to 1 mil per minute, which means it's significant bleeding. So that is one of the considerations. And this man, like you said, the HP was 4.5, and mesenteric angiography is quite a laborious and prolonged test to be done. I'm just wondering, this kind of patient could even die on the table because it's something you're moving the patient around and you're poking around. Um, but I'm just raising that issue. But then, yeah, there are some hands raised. I will come back to some of that. Dr. Shino,
Good afternoon, everyone. Good afternoon, everyone. Can you hear me, please?
yes, we can hear you clearly.
Yeah, two things. Dr. Oke has spoken very well. He talked about massive GI bleeding. Two things we need to be clear about what GI bleeding is. We also need to appreciate the fact that in most cases, let's talk about the lower gastrointestinal bleeding. The patient has hematochezia, right? What you should do in many a time is in 80 to 90% of cases, the truth about it is they usually stop with good resuscitation. Good resuscitation in this context, you resuscitate like a trauma surgeon. You're giving 4 units of blood, 4 units of FFP, and 4 units of platelet. You're going to that's how we do trauma, a balanced hemostatic protocol. That's what we should. That's what I would prefer, and I have a different perspective concerning that. That's what you usually do. We usually have adopted a balanced hemostatic protocol. Apart from that, we tend to do, let's say the patient is having, because the common causes, like in every situation in medicine, common causes are called commonly. A lower GI bleed, if it's a massive lower GI, it's probably going to be diverticular disease, angiodysplasia, and you also need to fully appreciate that in 10 to 15% of cases, why a patient is having massive hematochezia is not vomiting blood, and he has not vomited blood, he can actually be bleeding from a duodenal ulcer. That is why when we are resuscitating this patient, it's prudent to do an early GI scope, an early upper gastrointestinal scope to confidently, they did that in this particular case, to confidently rule out an upper GI source. Once you rule out an upper GI source, your work is a bit streamlined. You now focus on the colon. Where is it in the colon? What do I want to do? And like correctly pointed out, resuscitation is the most important aspect of this thing. So the varicose bleeding, those ones usually go to the, what do you call it? They usually go to the medical gastroenterologist. They don't come to surgeons at all. Varicose bleeding don't come to surgeons at all. But we are talking about non-varicose bleeding. Non-varicose bleeding, you talk about peptic ulcer disease, number one. Then as an upper source, and he has enumerated how we manage them from endoscopy, if endoscopy fails, surgery, But for the colon one, the one we have to deal with, the ones that have diverticular bleed, and occasionally we've had, if he had like the case he presented, there's nothing he couldn't have tackled the case endoscopically. He couldn't have. The only thing he could have done is to do the surgery that he did and do an anastomosis. So that's basically what we do. But another thing is that what we do in my institution, we don't do interventional, what do you call it? What's it called? Interventional radiology. We don't do that at all. I don't think in the protocol, interventional radiology, angiography, selective mesenteric angiography, are usually done in the context of a recurrent bleed. They're usually done in the context of a recurrent bleed. And like rightly pointed out, the patient must be bleeding about 0.5 to 1 ml per minute for it to be identified, and the bleeding vessel is selectively embolized. Thank you, everyone. And thank you, Dr. Oke, for the presentation.
Thank you, Dr. Oshino. I couldn't agree more with you on the points you raised. Resuscitation.
Yeah. Okay. Thank you very much, Dr. Sinawa. I know Dr. Sondu had indicated. I don't know this still one. Yeah, Dr. Sondu.
Okay, good evening, sir. Thank you for the presentation. Sir, please, my worry is, as you mentioned, early scoping saves lives. And I want to ask, is there any guideline or accepted procedure to achieve bowel preparation in this emergency situation? As you said, that endoscopy should be done within 12 to 24 hours. But the problem we have sometimes when we send patients after stabilization, bowel preparation takes about sometimes 3 days and delays endoscopy. So I don't know if there's any protocol accepted to achieve this bowel preparation in an emergency situation like this. Thank you.
Okay, thank you, Dr. Osondo. I think I need to talk to bowel preparation. That one somehow have been an apostle, and I've had a few converts to the simple fact that there is no need for a 3-day bowel preparation. You can get excellent preparation in 12 hours. There is the talk by Professor Jerome Dewey that's on YouTube, in which he said it does not matter what you use to prepare the bowel. Complete bowel prep is the most important thing. You plan a patient for 9 o'clock the following day. You give the patient the first dose of whatever laxative it is you want to use, magnesium sulfate base, PEG, whatever. You give the first dose in 12 hours. You give the next dose 4 to 5 hours before scoping, and you get the patient to drink as much clear fluids as they can. By the time you get there, I assure you 9 times out of 10, you might not see a speck of stool, and you may just be scoping on that clear water without even needing to use a foot pump. So there is no need for a 3-day prep. Now, in the emergency situation, the thing to do, which I said was a rapid prep, which is a bit difficult because it's difficult to drink 1.5 gallons of prep water, especially when you're sick. Even when you're not sick, you could throw up. So in this situation, if the patient is stable enough, has an NG tube, and you infuse 4 to 6 liters, you give this patient prokinetics, antiemetics, and you give them 4 to 6 liters of the prep fluid, preferably PEG. PEG is the one that has the best evidence to support it in acute situations such as this, polyethylene glycol. And wait 3 to 4 hours, and it will be clean. This also has been my experience in Lagos. So there is no need for a 3-day prep. However, in a situation like this where there is ongoing bleeding, you don't have enough time to push all of that down. You have to plan to go to theater. That speaks to the need for an experienced and skilled endoscopist. So we all have to keep working hard to improve our skills, and I did speak about enemas. Enemas can be done, irrigation can be done as you are going in through the scope by injecting saline with a 50 or 60 ml syringe, or a water pump with a foot pedal, whichever it is that you have access to. You clean, you advance, irrigate, you advance, you irrigate, you stop, you advance until you get to the cecum. So that's my own response to that. I hope it's clear.
Okay, just to add to that, like you said, in the patient who's bleeding profusely, time is of the essence. And even if you give the oral bowel prep, if this patient is still bleeding, then what you end up having is a pool of bloody fluid in there, which again will preclude adequate visualization. So I think the best approach is using a water pump if you have access to that. That is, you're going in, you're irrigating and suctioning it as you're progressing. At least you are ruling out where the source of bleeding is as you progress. Just as you did in this case, that most of the significant diverticulosis were on the right side. So you were able to localize that, because you even trying to prep a patient for 12 hours when this patient is bleeding, you can imagine that you really don't have the luxury of time in that situation. So that but again, from the principles is, if you have the access and the resources. And in this patient, I don't know if the patient was able to afford the blood products. I have an issue, because if the patient was able to afford the blood products, then resuscitation, adequate resuscitation would have been the case. And in most cases, with adequate transfusion of FFP's blood, most of the diverticular bleeding will stabilize and stop, and then you can scope them at a later date or at a later time, not So that would be the approach. I'm aware. Okay, there are three hands about Dr. Adeyeye, I think, and then I'll call Professor Coker after that.
Okay.
Yeah.
Maybe I have a question and like maybe an idea. Yeah. So about the question, the first is that what's our option if you don't have a foot pump, and there's a lot of bleeding, like maybe a variceal bleeding or a very bad colonic bleed. What are the options? Because I don't have a foot pump. I'm just wondering if I have
You
a
don't
very
have a
bad
foot
bleed.
pump.
What am I?
Okay.
For significant variceal bleed
That's
also, you may not actually have visualization. That's where you actually use even some very basic things like a stent stacking tube to
Yes.
tamponize. Once you use a stent stacking tube, you can tamponade the OG junction. The variceal bleed is usually from there, and then stabilize the patient. And then you can do your scope later when the patient is stable. A scope in a situation where the patient has a stomach full of blood is not the ideal thing, because you may not be able to identify anything then. But your first goal will be to stabilize that patient.
I totally agree
yes.
with you, sir. Sorry, Dr. Adeyeye, if you saw the diagram that I put up with the options, there's the sextachin Blakemore that Oga spoke about, but there's also the Danny stent. Danny stent also